look carefully at this X-ray. The patient presented with pathological fracture. You can see the pathological fracture because of a trivial fall. There was a fracture. On examination by the orthopedic surgeon, the calcium level was 11.3. So you understand, at this point of time, anybody who can tell me what is your rough suspicion? Hypercalcemia with pathological fracture. What is that?
Pathological.
Yeah.
Hyperparathyroidism.
Hypercalcemia of malignancy.
Hyperparathyroidism.
Hyperparathyroidism. That becomes more important, because if somebody has got a hypercalcemia, gross hypercalcemia, then usually the primary is obvious. But in this particular case, you find there is a pathological fracture with elevated calcium, hypercalcemia, which is a suspicion of a parathyroid pathology and a hyperparathyroidism. The next question is, how will you evaluate the patient? This is something which is commonly given in the OSCE. The answer to the question is serum calcium, urinary calcium, serum phosphate, urinary phosphate. So that becomes one part. The second one is, so there will be hypercalcemia with hypophosphatemia. The next thing that is asked once you do this, the next one is serum IPTH, intact parathormone level. It is going to be elevated. So clear? Now, this is the initial evaluation to confirm that this patient is suffering from hyperparathyroidism or not. So your initial evaluation for diagnosis should be serum and urinary calcium, serum and urinary phosphate, and IPTH, or intact parathormone level. Now, one must remember here that this calcium level can be a rough marker for a malignant parathyroid neoplasm. If you find that the calcium level is dangerously high, that is, they tell it is more than 12 to 13, in that case you can suspect it to be a parathyroid cancer. If it is less than 12 to 13, then it is usually, not always, usually benign parathyroid lesion. The third question that is asked is, what are the different techniques for localization? For OSCE segment, your answer should be number one, a high resolution ultrasound of the neck. So number one answer is high resolution ultrasound of the neck. Believe me, it is an extremely sensitive and specific test for localizing the parathyroid. And in our series, which ranges to almost 150 plus parathyroid now, we have maybe in 1 or 2 cases only missed the parathyroid in ultrasound. So do not omit ultrasound in your answer. It is an extremely sensitive and specific test. The next one that you are going to write, number 2 after this, is MIBI scan or system AB scan. In the system AB scan, you are going to get an obviously localizable lesion in the parathyroid. And the biggest advantage of system AB scan over ultrasound is the fact that it can localize ectopic parathyroids, which can often, or rather always, missed in ultrasound, because ultrasound cannot go into the mediastinum. So the answer is number 1 ultrasound, number 2 is an MIBI or a system AB scan. The number 3 answer that you are going to write is a SPECT CT. We routinely do a SPECT CT in all patients, and that's part of the international guideline. And these 3, that is a combination of ultrasound and MIBI scan and a SPECT CT, almost give you 96% preoperative localization. So the answer to the question will be 3. For evaluation, you are going to go for a serum calcium, urinary calcium, serum phosphate, urinary phosphate. For localization, you are going to write about ultrasound, you are going to write about MIBI scan, and you are going to write about SPECT CT. Now, SPECT CT and MIBI scan can localize the parathyroid, which is ectopically placed, better than the ultrasound. But in the neck, ultrasound and their sensitivity is quite close. The other question that is quite often not asked, but for you to understand, is that how we differentiate between hyperparathyroidism due to or hyperplasia or due to an adenoma. Now, in circumstances, just try to remember this. In circumstances where we find that the IPTH is elevated, the serum calcium is elevated, there is calciuria and hypophosphatemia. Now IPTH is elevated, you do an ultrasound, you cannot see anything. There is no obvious glandular enlargement. You do an MIBI, it may or may not show anything, or maybe it's showing 1 or 2 or 3 glands. So if there is no localized pinpointed lesion which is restricted to one gland, then we suspect that we are dealing with all 4 gland pathology, and this is an indication for all 4 gland exploration. If you have preoperatively found it to be localized to one gland, then it's a single gland exploration. So coming to the last question, suggest treatment option for single or polyglandular involvement. The answer is, if it is a single gland exploration, it's a single gland, then your answer is focused parathyroidectomy. That means you are going to open only that area where you think that the parathyroid is located, and you are going to take it out. If you suspect it's a polyglandular involvement, then it's called 3.5 parathyroidectomy. You are going to take all 4, take the fourth half of it, mince it, and put it in the sternocleidomastoid. If you can do a half parathyroidectomy at that point, that also is acceptable, but it has to be 3.5 parathyroidectomy. If you are dealing with a parathyroid cancer, then it comes down to in most circumstances, a parathyroid cancer is a diagnosis which comes after you have excised a parathyroid adenoma. Like follicular adenoma, where capsular in the thyroid, follicular adenoma in the thyroid, it depends on capsular and vascular invasion. Similarly, a parathyroid adenoma and a parathyroid carcinoma, it depends on the capsular and the vascular invasion. So quite often the diagnosis comes after you have excised. The only link could be hypercalcemia more than 13. So yes, if you know preoperatively, it is justified to do a hemithyroidectomy, or else you can do just a parathyroid gland excision. If there is a recurrence, you call back the patient and go for a hemithyroidectomy. Any question on this segment? Okay. So I understand you understood the parathyroid. It's pretty simple, but again, during the exam, what you should be writing in the OSCE is far more important, because OSCE is truly objective, and if you miss one point, you are actually missing a large number of points. We come to the 6th OSCE.
So
Yeah.
in OSCE number 5, you said if we know that it's a parathyroid malignancy, we will go with a hemithyroidectomy along with the surgery. And you said even like parathyroid adenoma and parathyroid carcinoma can only be differentiated by biopsy if capsular invasion is present and vascular invasion is present. So how will we know before the surgery that's a parathyroid malignancy or not?
Very good question. Now, normally, as I said, in most circumstances, it is impossible to differentiate. There are a group of parathyroid carcinomas who present with neck metastasis. So in them, it becomes easier. In our series of 150, and it is one of the largest in India, we have till now had only 3 parathyroid carcinomas. And only in the third one we had a strong suspicion, because they have said that there is the parathyroid adenoma have a capsular breach radiologically. In this patient we chose to do a hemithyroidectomy, but still it recurred. If you do not have a radiological suspicion in terms of, like, a follicular adenoma and carcinoma is very difficult in an FNA, but in some follicular carcinomas might have an invasion beyond the capsule. So if you have a macroscopic invasion beyond the capsule, yes, or else in most circumstances, it is very difficult to know preoperatively that you are dealing with a parathyroid carcinoma. Clear?